I'm not an editor of
Barney,
I'm not an editor of the BJS. I decided I would talk about one paper because I'm a simple kind of guy. I reckoned that there would be few of you in the audience who would look at the endocrine papers in great detail, and on that basis I've chosen a paper which is also somewhat unique in endocrine surgery because it's a randomized controlled trial. There are very, very few of these in endocrine surgery. So as part of the brief I received, I looked at the titles of the endocrine papers with these search words over that 10-year period and laboriously went through them and looked at for two things. One, which paper would confirm the prejudices that I already had and would be reasonably simple for me to put to you in the time allowed. This is the paper that I've chosen. In the UK, we are lagging behind the rest of the world in the use of intraoperative neuromonitoring during thyroid surgery. I think with good reason. But in America and continental Europe, it is very, very difficult now to argue the case against the use of intraoperative neuromonitoring. That's why I like the study, because it's a randomized trial, it's asking a very clear question and it gives a very clear answer. To remind those of you who are not familiar with the neck, the recurrent laryngeal nerve and its injuries is one of the two real hard outcome measures that we look at in thyroid surgery. The rate of vocal cord palsy after thyroid surgery is a quality indicator, and its companion, the rate of hypoparathyroidism, are quality issues that we're constantly trying to improve. I said this is a very popular topic. I searched using Google and PubMed on these, and there's an awful lot out there. The article in the Wall Street Journal in 2001 effectively said, for American surgeons, if you don't use a neuromonitor to test the function of the recurrent laryngeal nerve, effectively you could be found negligent in the American courts. It caused a huge furor. And it's fair to say, certainly in the UK, and probably in America too, that this tool, intraoperative neuromonitoring, is very frequently used by ENT surgeons performing thyroid surgery and less frequently used by general surgeons, endocrine surgeons, doing thyroid surgery. So to me, the paper is very important. What does neuromonitoring in thyroid surgery involve? 3 bits of kit. The box, which costs about £10,000. A special endotracheal tube, which has an electrode on it, in blue on this slide, that rests on the vocal cords. It needs very careful positioning by your anesthetist. And the little black thing on the bottom of the slide is the probe that you use during the operation. And the cost of the disposables is about £250 per case. And that's important because according to the tariff that we get in the UK for thyroid surgery, if you use this instrument, you're never going to meet your payments. So there's a practical and pragmatic reason to avoid the use of the neuromonitor, never mind whether it's any good or not. The British Association of Endocrine and Thyroid Surgeons requested an appraisal from NICE on this. And that's the first line of the guidance, which probably tells the whole story. If they're talking about safety rather than efficacy, that's a relatively unusual way of going around this matter. And the second part of the guidance, the bullet point of the NICE guidance, was equally vague. So that probably tells you at outset there's relatively little information on which to base a clear decision. NICE looked at the evidence available at the time. Well, you can see there's an awful lot of patients. 32,000 nerves at risk, or more than, is 16,000 patients have been studied so far. But none of these were randomized studies, and they were unable to show in non-randomized studies any significant difference in permanent or transient vocal cord palsy rates. If you talk to the advocates of the intraoperative neuromonitor for thyroid surgery, they say the same few things every time. It helps you identify the recurrent laryngeal nerve, but actually there's no real evidence to show that. we've been using the same way of identifying the recurrent laryngeal nerve for a very long time. They say it's good for teaching, but I'm not quite sure why it's good for teaching. They never really explain that. And finally, that it decreases the liability risk. And the users, as pointed out in this paper in the World Journal of Surgery, are keen to believe that, and the disbelievers don't agree. So what about the BJS study? They looked at 1,000 patients having bilateral first-time surgery over a relatively short period of time. That's an awful lot of thyroid patients over this time period. So one of the flaws of this paper is that you're looking at experienced or even expert surgeons who probably, on the basis of volume and outcome, have very good outcomes. It's difficult to improve with this technology in this study. That's probably, I'm not sure whether, I didn't referee this paper, I don't know what the reviewers of the paper said, but that would be one of my comments on this study. There was no significant difference in the patients who underwent nerve visualization or nerve neuromonitoring in terms of these important issues in the selection of patients. They were very well matched. And they very carefully looked for post-operative vocal cord palsy. Now, in most reports, the incidence of transient vocal cord palsy is not looked at 48 hours. If you look at cord palsy rates in patients 48 hours post-thyroidectomy, the rates will be much, much higher than one would normally expect. Most vocal cord palsies recover very quickly. But they went on very carefully to document recovery and to define their permanent cord palsy rate. And what they showed was impressive. It was impressive because with nerve visualization or nerve monitoring, at 48 hours, the rates of nerve palsy were very, very low. And they were unable to show any difference in the permanent vocal cord palsy rate. Transient nerve palsy was less common in patients with neuromonitoring, but the permanent rate was no different. That's the real take-home message from this study. They also showed that if you lost your signal, and in this slide that's the positive predictive value, in 2 out of 3 cases, the loss of signal, that is what you would assume to indicate a nerve palsy, in 2 out of 3 cases represented a technical failure with the equipment. And this is important because another argument for the use of the neuromonitor is if you're doing a bilateral thyroid procedure and you lose the signal on the first side, maybe you should stop the operation in case you cause a nerve palsy on the other side and the patient's at risk of a tracheostomy. But what this study showed, which I like, is that in most cases, if you lose the signal, you need to check the equipment very carefully, rather than believe you've caused damage to the recurrent laryngeal nerve. Another benefit from the study, which doesn't contradict my prejudice, is that maybe the intraoperative neuromonitor is good for saying whether that tiny little filament that you think is a blood vessel is not an anterior branch of the recurrent laryngeal nerve, because it's actually these tiny filaments of the anterior branch of the recurrent laryngeal nerves that are really crucial. They're the motor fibers to the vocal cords. They look like very little, and if there is technology that helps you protect those, that's a good thing. But in this case, it hasn't altered the permanent palsy rate. They also showed the nerve monitor was of more benefit in high-risk cases in reducing the risk of recurrent nerve injury. But the take-home message I will keep saying to you is that there was no difference in the permanent palsy rate, which many people would say is the only thing that matters. So, as I've already said, the bias of the study using expert surgeons, and therefore the narrow window for improvement, is important. But if you look at the only other big study, non-randomized study, which looked at a large number of nerves at risk, that is getting away from the expert impact, there was no difference in nerve palsy rate in the published study. The other question to test the validity of this study is whether or not it was powered enough to answer the question. And it probably wasn't. But if the risk reduction is so low anyway, I'm not sure that increasing the number of patients in either arm to show a very small improvement would make this technology any more worthwhile. So the title that we were given was Have Changed Clinical Practice. I don't think it has as yet changed clinical practice. I don't know whether it will change clinical practice, but I would say to you that I think it should change clinical practice. Thank you very much.